So, Dr. Palacios, are you ready?
Yeah, I'm ready.
All right. So, Kevin, can you please make Dr. Untracht, Dr. Hochman, and Dr. Kassim as well as co-hosts, so we can
Yes.
so they can jump into the discussion. That's perfect. All right. So, Dr. Palacios, thank you very much for being able to present this meeting today. We are very, very glad to have you here. I think it's at least in the last couple of meetings, probably this is one of your first presentations right here with us in this, I don't know, the last sessions here. So that's very interesting. And since you are from Ecuador, it's nice to have you as well, because we're going to have the next PTS meeting in Cuenca, right?
Yeah, you're right.
Yeah, so that's perfect. All right, Dr. Palacios, feel free to start whenever you want. And I don't know if you have already selected specific parts in the presentation where we can discuss, but if not, I can just pause you and we start the discussion with the panelists as well.
Okay. Are you seeing my screen?
Yeah, we can see it.
Yeah. Good morning, everyone. I'd like to thank all the organizers for the opportunity to present this case in the PDS meeting. It's my first time. I'm Dr. Palacios. I'm one of the general surgeons in Marco Vinicio Isaac Hospital. This is a public institution. It's a secondary healthcare provider. It is located in Lago Agrio, Ecuador. The city is near to Colombian border. You can see the map. This is my country. This is the border. My city is here, Lago Agrio, and this is my hospital. I have no disclosures. The objectives of presentation are: number one, analyze the possible injuries and discuss management and strategies in penetrating trauma. And number two, diagnostic workup and education for surgery. Today, we are going to talk about an interesting case. We have a 35-year-old female who came into our hospital with multiple stab wounds. She was victim of penetrating injuries 30 minutes before arriving, and the past medical history denies. In the ER admission, she arrived 9:20 p.m., hemodynamically stable. In the primary survey, A was intact, B, no respiratory distress, C, heart rate was 74, blood pressure was 170, disability, GCS 15, and exposure, we note multiple injuries demonstrated on the picture, which you can see. I'm going to explain the injuries. Can you see my pointer? Yeah. 6 injuries located in the upper back, 1 injury in the epigastric, and the last one in the cardiac box. I was little concerned because it's important to evaluate this injury in that site. When the patient arrived at the trauma center with cardiac injuries, the clinical presentation including asymptomatic pericardial tamponade or shock. In the secondary survey, tenderness in the left upper quadrant and diffuse guarding. The treatment in the trauma bay was starting intravenous line, no oxygen supply, no transfusion. What next? Local wound exploration, subside pericardial window, chest X-ray, EFAS, or CAT scan.
Great. That's a great start. Dr. Hochman, shall we start with you today?
Sure. What we will do, the first thing is the chest X-ray, because we have it very easily available in the trauma bay, and the EFAST. Which one first? They both go kind of almost simultaneously. In the chest X-ray, she has multiple stab wounds in the back, And maybe the problem originates in the back and not in the front. So that's the problem when you have to maybe start thinking about surgery, how you're going to position this patient. So the pneumothorax, you can diagnose with EFAS. The size of the pneumothorax is better diagnosed with the X-ray, and we will see if there is a pericardial tamponade. She probably has something in the abdomen, but I really at this time I don't care. The most serious injuries, if there are injuries, it will be in the chest. So that will be the priority. Local wound exploration, we don't do anymore, and we don't do it in the chest, and so that would not be an option. And successful pericardial window, if you don't have any fast, that will be the next step. This patient needs to go to the OR because it has peritoneal signs. So if the chest X-ray is negative and I don't have an EFAS that I can do to rule out a pericardial window, this patient goes to the OR. First things is a successful pericardial window, followed by whatever, if there is fluid in the pericardium, median sternotomy, and if not, an exploratory laparotomy. Thank you.
That's great. Dr. Untracht, any other additional comments?
Yeah, I agree with all that, although I might do it slightly differently. First of all, I noticed the sutures in the wounds. I guess that was done in your ER. So instead of doing that, I would have done an EFAST. I just do that all the time. Where I am, it's actually a little faster than getting the chest X-ray, even though it's close by. But I would have ruled out a pneumothorax, and then cardiac, the pericardial effusion, if not tamponade. And then I would have looked at the abdomen, probably seen something in the left upper quadrant, would have been positive. And if that were negative, if anything cropped up, if there was a pneumothorax, I just straight away put a chest tube even before a chest X-ray. And if it was negative for tamponade, and even if it was positive in the abdomen, because she has so many stab wounds, I think in this case, it's reasonable to go to CT if it's readily available nearby on the way to the OR, whatever, because she's stable. I'd still go with her, but still do that to know what you're dealing with. And I agree with Dr. Hochman that she needs to go to the OR probably for a laparotomy, but you would rule out a subtle injury that may cause trouble in the OR. You'd want to, and a CT would be very good at showing you that. So that would be the approach I would take. And instead of suturing, that time you could have done the EFAST and the CT, or the EFAST chest X-ray and go to the OR, and really is no point in doing the suturing.
Great. Dr. Kassim, would you agree with the idea of doing at least a chest CT scan before going to the OR as well, or would you do anything different?
Well, I look at this case as the one where my teacher taught me, go to the place where the patient most likely will die from. So in other words, what is the injury that is going to kill this patient as rapidly as possible? So that will be the box. That is where my attention is going to be. And several months ago, we had a case of abdominal injury with a stab wound like this. And I said, it is mandatory to go into the abdomen at that time. And the professor Nehemiah from University of Miami taught me that is not the current thinking. So I learned something from that. So I agree with both my predecessors' evaluation of this case, but I think the most important thing in this particular case would be to rule out cardiac injury. Although the cardiac ultrasound will give you some clue, sometimes it doesn't. So I will do it, but I would not put all 100% reliability on it. So I would go ahead and do subxiphoid incision in the OR to see if I can definitely determine that there's no pericardial effusion, especially blood, which may give rise to cardiac tamponade. And then after that, I would reassess the patient to see what would be the best thing that I would do. Chest X-ray definitely will be a good idea initially when the patient arrives in the trauma bay, but I don't think that I would resort to CT scan on this particular patient, even though she's stable.
Dr. Menegoso, I can see a question in the chat.
Yeah.
Dr. Clever Panta answered the question. I suppose the intention of that question is we have a large terminology about the cardiac box, the Murdoch danger zone, the cardiac proximity, etc. What is the area is the best predictor for cardiac injury? I suppose that is the intention.
Yeah, probably, yeah. And Dr. Untracht had his hand raised, and also Dr. Untracht, after your comments that you want to make, do you want to answer the question that Dr. Panta raised in the chat as well? Do you want to make any comments on that as well?
Sure. What was the question?
So he asked if there's any better discriminator of cardiac injury among the things that we say, for example, the cardiac box, the cardiac proximity, precordial zone, anything that is related to it.
Yeah. Well, let me just make my comment. I meant to say during my original comments that the history in this case, I think it'd be fairly important because the wounds are narrow. So it looks like, I would guess, maybe a kitchen knife, a steak knife, whatever, which isn't very long. So in the back, I wonder if any of those would have entered the thorax, because on down it was mostly on the right side, to the right of the spine. So, to the left of the spine, it can potentially injure the aorta, but probably not a very deep knife. So whether or not she was stabbed in the house, whether it was intimate partner violence or out in the street, that would I think that would be an important part of the history. But it looks like it probably wasn't a very long knife based on the size of those wounds. And then about the comment, what are the indicators? Well, I'm not sure that anything more than the position of the wounds. And in that case, it's really, if it's at the box, it's at the lateral edge. It's the upper inner quadrant to the left breast. And, so it depends on the way she was stabbed. And, if it's a right-handed assailant, I would assume that it would have gone medially. But I think, as all of us would do, is just err on the side of assuming it's in the box and she was stabbed in that area. So I think that's a sensitive, it's a sensitive but not specific indicator. It's enough that you'd want to, just assume that the injury could be that the stab wound went in an area where she could have injured something in the mediastinum or within the pericardium. And you need, as Dr. Kasim said, you can't rule it out with an ultrasound, but if you're pretty confident about getting a good picture and you don't see anything obvious, that she, if she has a mild injury and there's a subtle fusion, that she won't decompensate within a few minutes, So I just assume anything near that, like as you did, that it's in the box and you need to put number one, potential intrapericardial injury.
Perfect. Agree. Dr. Kasim, you have your hand raised.
Well, the classical teaching is anything medial to the left nipple would be called the box. And Dr. Coimbra taught us that has been extended to the lateral or mid-clavicular line area. He called it Ziegler's line. And so the box is bigger than what I was taught when I was a medical student. So this particular injury will definitely classify as within the box. So I would be scared to rule out, I would be scared to miss any cardiac injury.
Definitely. All right, Dr. Palacios, what did you guys do with the case?
Okay. I have the lab results. White cells, hematocrit, hemoglobin are normal. We proceed with X-ray. You can see no hemothorax, no pneumothorax, and mediastinum is normal. EFAS was negative. Morrison pouch, free fluid, no pleural effusion, lung sliding is normal, and subside view, no pericardial effusion. Any comments here? Next step, surgery or no operative management.
All right. Dr. Untrax, want to jump into this
Well,
one?
I guess I would call it the latter, but I would go to CT in this case because I wouldn't just take her to the OR based on that. And again, you probably have some information about the context of the injury, all inside the house, outside what, the kind of knife, and then I would go to CT because she may be a situation where none of those penetrated. Although if that were the case, you wouldn't be presenting the case here. But if she's stable now, you did all that, and I would, because she could have an injury above the diaphragm, below the diaphragm, it still may be intrapericardial, it still may be intrathoracic, and you would get a better look, and if you have access to it, I would do it because it would get you to, I'm assuming she needed something done, and this will tell you where, which of those 8 or 9 wounds is the one that is the one that causes the injury. So that's what I would do. If you were in a hospital without access to CT, then you could do things like start exploring wounds or careful observation to see how it evolves. But I would exclude the first one right away, because if you go in the abdomen, then guaranteed, at least in America, you do that, guaranteed that the problem's going to be in the other cavity. So, in this case. But anyway.
Excellent. Dr. Hochman, any reasons to take this patient to the OR now?
Well, if I remember correctly, this patient had peritoneal signs, so she would need to go to the OR. A few things. The ultrasound kind of replaced the subxiphoid pericardial window. I used to do a lot, and I hardly ever do one now, because usually when it's positive, the patient is really in bad shape, and we go straight to median sternotomy. But it's an option if you are concerned. But the negative FAS is usually because you have leakage from the pericardium inside the pleural cavity, and this patient have negative chest X-ray. So I think it's possible still, but I think it's unlikely. I agree with Dr. Untrax. If this patient is hemodynamically stable, a CT scan can give you a lot of information. She probably need to go to the OR, but you can make sure that you are not missing anything, because you don't want to start a laparotomy and suddenly the patient becomes hemodynamically unstable because you missed something in the chest that was missed on the initial ultrasound or CT. The FAS in penetrating trauma in the abdomen, I really don't care too much, I will be honest, because many times it's negative. You need to have, at the bare minimum, at least 500 cc's of fluid in the abdomen to be positive. So if it's positive, it gives you an answer, but if it's negative, you don't have an answer. But this patient has peritoneal signs, so I wouldn't really worry too much. She needs to go to the OR, probably with a stop at the scanner first. That would be what we will do here. Thank you.
Yeah, that's very nice that you remember this. And it's so, I wanted to ask Dr. Palacios, do you know if you looked for hemothorax with the ultrasound as well? And if you is there any part in your survey, in your place, where you look for pneumoperitoneum with ultrasound as well in trauma patients?
In this case, I'm not consider a CT because the patient present a peritonitis sign, and that is enough for me to carry or to care for operating room. The indication surgery is hemodynamic instability or peritonitis in this case. This is I'm not considered that CT.
And
In the physical examination, no dyspnea or other symptoms, no pneumothorax, and the X-ray and EFAS was negative. It's enough for me.
Great. So we're considering that the EFAS did not show any signs of hemothorax as well, because this is a very important false negative sign for an EFAS in a trauma patient, right? Dr. Kasim, any other suggestions? Any other thoughts?
Well, my teacher used to tell me, when everything is negative, be careful, you're going to be called an ass afterwards. And so this patient is showing everything that is negative, and yet you're wondering what could be lurking behind all those stab wounds. And sure, the patient has peritoneal signs, and would that be good enough to go into the abdominal cavity to explore immediately before you rule out all other possibility in the chest and the heart? No, I don't think so. I think, like I said, I would do a chest X-ray. If there's no hemothorax, I would take the patient to the operating room to do a subxiphoid incision to make sure that I'm not overlooking any injury to the pericardium or pericardial effusion or pericardial tamponade. And then I have to make a decision whether I carry on with my incision into the abdominal cavity or not. That would be my plan of management. And I appreciate the value of the CT scan, and it is used widely and for good reason. And I also agree with Dr. Untrak saying that CT scan would be very valuable in this case, but I'm already in the operating room, so my CT scan would be on the bottom of my list at this moment. Thank you.
Great. Dr. Untrak, you had your hand raised?
Yeah, you raised an interesting point about the fast, and about pneumoperitoneum. I don't know what Dr. Hockman and Dr. Kasim think, but I don't think if you have a pneumoperitoneum and there's a large amount of gas, you won't see anything because the gas will interfere. But interesting point about the hemothorax, and the images, Dr. Palacios' images went by quickly, but when you do look at the spleen and the diaphragm, you can see right away very quickly if there's blood above the diaphragm, and maybe Dr. Palacios can show us those images again. But below the diaphragm, you should see the spine through the kidney and medial to the kidney, medial to the spleen or the liver. And then if you also see the spine above the diaphragm, the only way that can happen is if there's fluid in the pleural space. You have bleeding, but you should lose the spine as soon as it intersects the diaphragm going cephalad, and then you shouldn't see it above. So, you have that information immediately when you do the EFAS. It doesn't require a lot of extra time or other images. So I don't know if Dr. Palacios has those, if it's easy to replay, but I think that would show on either side that you just don't see, you see the spine, then as soon as you get at the diaphragm and go above, you don't see it anymore. That's a very, very sensitive sign.
Yeah, that's a
the other thing about the operating, I want to say, so, if you do non-operative management, then you see that, sometimes the peritoneal signs go away. And then the other option, if you still don't feel comfortable, what would you do in the OR? A lot of places where they have 20 of these every night, and they're too busy to operate on everyone, they'll put a scope in and see if the peritoneum was violated, first. And if it's not violated, then okay, they're done. If there's no fluid, not violated, no enteric content, so that's also an option. I would imagine. I don't know what Dr. Hockman feels about that, if they use that very much in Tufts, but that is often one possibility.
Yeah. So what you're saying is that, considering that the patient maybe he may have intra-abdominal injury, we are relying on the peritonitis, on the peritonitic physical exam, but the patient is stable. So considering laparoscopy, maybe, right? So
so I guess you don't do that anymore, Dr. Hockman, in your hospital, and Dr. Kasim?
we do laparoscopy if it's only the abdomen, but in a patient like this, I really need to be absolutely 100% sure there's nothing else going on before I commit to laparoscopy. If it's an isolated stab wound to the abdomen, so we have like a stab wound to the abdomen algorithm. If the patient is hemodynamically unstable, or it has momentum coming out or have peritoneal signs, they go to the operating room. The other patients, if they are not intoxicated, which I still have to have one patient who is not intoxicated, so that's the reality. All of them are intoxicated, or they are not suicidal, or they don't have a severe psychiatric history, or comatose for another reason, we can try non-operative management. But as again, all my patients, I don't remember, I'm not joking, I don't remember a single patient who came that was not intoxicated. So they all have something to be done. So you have a patient who you are not sure if he has an injury, is intoxicated. So in those cases, even for blunt trauma, when we see fluid and no solid organ injury, if the patient is hemodynamically stable, we will start with laparoscopy. And if we can explore correctly, we can see the bowel, we can see everything okay, we do it like this. We have a few cases that we did a mini laparotomy to just repair a perforation in the small bowel. We have cases that we have a bladder injury that was repaired with a mini laparotomy after identifying that. One of my partners recently did one robotically, a small bowel injury, which was great case because the patient has just only the holes from the ports. So there are other options, but the patient has to be a patient that you are not worried about anything else. And this case, I don't know. I had a feeling this is being presented here. I have something bad. So
But can I say, in this case, this is the case where you can never be sure, because there are so many. Most of the stab wounds are above the diaphragm in the chest, so you're going to the abdomen, so you don't, and you don't know. But I guess there you go. That's why the case is being presented here. There you find out.
and the patient will be ventilated with positive pressure, and this is the patient that suddenly will develop a tension pneumo or something like that. And when you're doing a laparoscopy, and so it's kind of like there was an old concern about patients with diaphragmatic injuries doing laparoscopy that you might develop a tension pneumo from the pneumoperitoneum, induced pneumoperitoneum. I had a few diaphragmatic injuries that I did laparoscopically, and I never had that problem. Most of the patients don't even develop a pneumothorax. I had only one that I had to put a chest tube. And the main reason is that it's in positive pressure ventilation. And usually they can overcome the positive pressure ventilation, the pneumoperitoneum. So that's not really a concern of mine. But in this case, she has too many stab wounds. I would be very worried about what's going on in the chest.
That's great. Great discussion in this case so far. Dr. Palacios, please move on. Let's see what you do.
Okay.
What you did.
The patient was taken to operating room and start with exploratory laparotomy. The procedure was open the great sac and exploration supra inframesocholic compartment and Cocker maneuver. The initial findings were mesenteric tear, a double injury through the anterior wall D2 portion, injury transverse colon, hemoperitoneum 100 millimeters, and no contamination. I have the real photographs of the surgery, and this is the graphic. This is the site, the injury, and you can see in the photograph. This is the duodenum in the D2 portion. The injury is here, and the other is here. Superior and inferior injury and duodenum. You can see the bile in the gauze, and here is the hematoma. I decide when I find this hematoma, I decide to explore and find this injury. And this is the mesenteric tear. In this slides, I have the double AST injury scoring scale. How we proceed? We have 4 options: primary repair, pylori exclusion with gastrojejunostomy, pylori exclusion without gastrojejunostomy, primary repair with drainage. This is the gastrostomy, this is the duodenostomy, and this is the feeding jejunostomy. Which one you prefer?
Great. Let's start with Dr. Kasim.
Well, keep it simple. KISS. So you already told us you didn't see a lot of contamination except for some bile leakage. And I would oversaw that you oversaw the colonic injury first. And then I'll come to the duodenum, and I would take primary repair of the duodenal injury without any further diversional surgery as indicated in the diagram that you're showing us. For the very simple reason, there is not much contamination, and you are addressing this patient's injury rather quickly, and you should be able to get primary repair of the 2 holes in the duodenum and a single hole in the transverse colon, and get the patient off the table back to the ICU as quickly as possible.
Right. Dr. Hochman, any different approach?
No, I will probably do the same thing. The patient is not in shock. The hole in the colon appears to be small, so this is for primary repair. The duodenum, the way I will approach this, and maybe this was done, I don't know. I will start, first of all, when I have an injury in the duodenum, I will do a very wide Cocker maneuver. And this starts by taking down the hepatic flexure of the colon. So the colon has to come down. And after that, because what I will be concerned based on this location, the pictures I saw, is an IVC injury. Going through and through the duodenum and having an IVC injury. IVC injury, surprisingly, they tend to tamponade only to bleed late. So I will need to rule that out. So I will do a wide Cocker maneuver. The Cocker maneuver for me in trauma is to the left of the aorta. And I know that this is not described, that you have to go to the aorta. I go to the left of the aorta, so I make sure I'm not missing anything. And after that, when I have the duodenum in my hand, I will decide what I'm going to do, which, as Dr. Kasim said, you go for the KISS principle. The most simple thing is just to do a repair. And if you need any concern, you can use an omental patch, maybe. I will reserve the pyloric exclusion only when you have severe devitalized duodenum and maybe combined with a pancreatic injury. The last 2, the pyloric exclusion with jejunostomy and the other repair, I would never, I don't think I ever did any one of those, mainly because, particularly the last one, you're making more holes. The patient already have enough holes where he or she can leak. So keep it simple. So it's either option 1, or if that's not too good, it would be option 2, and that's it. That's where my whole approach will end. Thank you.
Perfect. Dr. Untrak, do you agree? Would you?
Yeah, I agree with both Dr. Kasim and Dr. Hochman. So what you have to presume in this case, if those were the injuries, so no posterior injuries in either the colon or the duodenum, that the knife went in, injured the colon tangentially, and then through the interwall of duodenum, he stopped, pulled the knife out, went in again, got the second injury, and stopped before injuring the posterior wall. So I would be very skeptical, and I'm sure Dr. Palacios did, as Dr. Hochman said, look very carefully so as not to miss a posterior injury. But it's actually very good. These these assailants, they should have just, studied harder, gone to med school and become surgeons. I mean, the way they do this, I mean, or we only see the good ones. We only see the skilled assailants, their work. But and so that's what I would be concerned about. And I wouldn't do any of the other fancy stuff, but I would leave a nasogastric tube just because I'm old. I would do that. Probably the young guys don't do that. My last comment is, Dr. Hochman, if you had taken this patient to do laparoscopy, you would have found all these injuries and repaired them with a scope. There you go. You would have seen that.
If I see the colonic injury, I will compare. That's it.
Really? Who's the? I'm blanking on.
No, the one who probably will do this is
Dr. Collet.
Dr. Collet, Francisco.
Or his colleague, the one.
Francisco Collet is the one that will do.
No, who's the other one from Brazil that he'll do everything?
Progetti, but the one who really does all laparoscopically is Francisco Collet. Progetti is another brilliant surgeon, but
but you know who he is. This is someone else from a different town in Brazil who really he takes it to the limit. Who am I thinking of? I'm blanking on his name, Dr. Menegoza. Do you know what I mean? Not Dr. Clay, different hospital than Dr. Yeah, he sits in the big room with all the students there, and he's
right.
Yeah. Dr. Castle may know what I mean, but anyway. But he would have done that. Dr. Clay also, they would have sutured it up, and showed whatever.
Yeah.
Gustav. Isn't it Dr. Gustav somebody?
No, Fraga, Dr. Fraga, that's it.
Fraga.
Yeah,
Gustav
right.
Fraga.
Yeah, and Dr. Calais also, he's done some of those, but they really push the envelope. And in 25 to 50 years, for sure, that's going to be standard. They're going to be making fun of us for slicing open.
I don't know. I think this patient has too much, but anyway, yeah, maybe somebody more skillful can do this. I think that doing a wide Cochran maneuver and making sure that it can be done, but it takes time. I don't know if this is the case that, and also if by any chance when you do the Cochran maneuver, you find out that the patient had an IVC injury, now you are in trouble trying to open quickly to get control. So I don't know.
They put 2 vessel loops around the IVC. It's right there, and take them to the cath lab. There you go. Whatever.
Yeah. Just to tell you about this, I've been to a lot of these surgeries laparoscopically, also with Dr. Collet, and in our hospital we do a lot of laparoscopy in trauma. But what we do is, every time that we go with the scope, we do a CT scan prior to that. So probably in this case, if we did a CT scan before the surgery, and maybe we found some retroperitoneum or any signs of the duodenum injury, probably this patient would go to a open surgery. But we try to do it laparoscopically, but sometimes, especially when you're considering the IVCs, as Dr. Hochman said, I don't think this case would go to laparoscopy, even if we had a CT scan beforehand. But it's an interesting discussion, because we like a lot to do it laparoscopy. We always try to do it, right? So
would you give this patient oral contrast for the CT?
Probably not. We don't use oral CTs for at least for laparoscopic approach. We tend to use it in intravenous and check what we see. All right, Dr. Palacios. So, what did you do?
Okay. The surgical procedure was primary repair duodenum with Vicryl 1 layer. Colon was repaired with primary suture, no drains, abdominal closure. In my group, I have a questions for panelists. What are your thoughts about drains in this case? Oh, is indicated or not?
All right, Dr. Hochman.
And I know one of my partners is on the call. I never leave drains, and I get in trouble with my partners because they tend to leave drains. This is something I remember when I was in medical school, which was in the prior century. It has been already demonstrated that you cannot drain the peritoneum. You can put a drain in an abscess or something like that, but the drains while open in the peritoneum, they don't work. And so far, this has been what I have seen what happen when drains get left, like, oh, let's see, repair the colon, let's leave a drain there. If it leaks, anything will come out through the drain except what you expect to come out from the drain. So I personally don't leave drains in a case like this. I know that I am in the tiny minority for this, so, but I have at least some literature to back me up that was written in the prior century. So maybe somebody said something new.
I'm on your side as well, Dr. Hoffman. So, Dr. Untracht, what are your thoughts?
Yeah, no, I agree with that. And I went to medical school in the second millennium, so the last millennium. So, and you know, the problem is, even if you leave a Penrose drain, a passive drain, before anything happens to those repairs, the drain will get walled off. So your suction drain, I assume you leave a suction drain, that'll get walled off, and you know, there's no active infection, as Dr. Hoffman said. Any drainage is going to be after the drain would get walled off, and then the patient won't be doing well, but you won't see drainage. You say, yeah, but there's no drainage. You know, you don't expect that. So I agree. There's just no point in this case. You know, if you had something where you had to form a controlled fistula, those are situations where there's going to be active draining from the beginning. You know, but not in this case. You know, you just go by how the patient does. You have ways to follow up. You know, nothing's going to happen for 5 or 6 days anyway. You know, and then you'll do other studies. You do a CT with contrast. You do the rectal contrast if you think it's colonic. But I would not leave drains.
Great. Dr. Kasim, what about you?
They say judgment comes from experience, experience comes from judgment. So it all depends on how confident you are in your repair of the duodenal injury. I would not bother putting drains in the colonic injury. I've never done that and never will. But as far as the duodenal injury is concerned, when you have 2 holes in the duodenum, sometimes your repair may not be as good as a single hole. So at least I would consider it. The second thing about the drain is a two-way street. Things can come out, things can go in as well. Sometimes if you don't manage the drain very well, all kinds of bugs go into the peritoneal cavity. Be aware of that. The third thing is Dr. Untracht is absolutely correct. You put a drain in, you leave the holes open, and the holes will get plugged. So one of the surgeons I used to work with many, many years ago was he would take a red rubber catheter and put another red rubber catheter inside it so that the inside one will have holes in it, the outside hole will get plugged, and you will still have an effective drainage. Something to think about if you're going to be draining it. By and large, if you have done an excellent repair and you're confident and providence is on your side, you don't need to drain this.
That's great. So there's a question from Dr. Kobe on in the chat. So he's asking, what signs do you consider suggest duodenal leak when you don't have drains in this situation? Dr. Untracht, do you wanna tackle this one?
Yeah, you see how the patient does. So, you know, if they start getting bowel sounds and they move things through, and I would have a nasogastric tube. So you see the drainage slows down, and, you know, and then just the exam, clinical signs. And then if I'm concerned, you know, if it was a clean injury and, you know, good quality duodenum, you oversew it, then I would leave drains. If I were concerned, I might put a duodenostomy tube. So if any drainage, it would be internal drainage to relieve the pressure. And then if you do that, then you have to decompress the stomach, and a nasogastric tube is fine. You know, if you're really worried, then you do the, you know, the G tube and the duodenostomy tube and the feed me, drain me tube and all of that, and you know, up to the ladder to duodenal exclusion. But you go clinically, and then if I'm concerned, nothing's going to happen for a few days. If the sutures pull out overnight, then there's really, you know, there was a misjudgment in the OR about how to proceed. But and then I would do, you know, do a CT with the oral contrast at that point, or the colon. If you're worried about that, you can give rectal contrast, or you know, to follow it back. But assuming you have access, I would do that. If you don't have access and you're in a remote environment, you can consider leaving a drain, but you may not. You know, it's not. You can't use that as for false confidence. It's just not. You know, for the reasons Dr. Hochman mentioned, it won't show. Often you may get a leak, but the drain isn't going to do anything. The drain isn't going to show it to you, and you know, it won't help. You know, and if you do get a leak, often it may be contained, and you can do the radiologist can drain it for you percutaneously. You get a controlled fistula, then that's something that's a good way to manage it in a way that the drain would not be helpful in this case. You know, if you went in there and you saw already a cavity forming, you know, you can drain the cavity, it contains space, but not, as Dr. Hochman said, the entire peritoneal space.
Great. There's another question from Dr. Panta here in the chat, and I'll leave this question for Dr. Hochman. So he's asking, what is your opinion about early oral feeding after a primary repair, such as in this case?
It's a difficult question to answer. We tend to do early feeding, but it will all depend on the clinical situation. If it's just simple repair, probably we'll do early, like 1 or 2 days after the injury. These patients are usually not simple. It's very unusual, like to have one stab wound into the duodenum and nothing else. They have other things. They've been in shock. They have altered mental status, so you cannot have exam. So I will leave an NG tube like Dr. Untrax mentioned. So if the NG tube outputs start going down, I take it out. And if the patient is doing fine, which is the criteria that we'll use, have no fever, no white count, it's unlikely to have a leak. So I will feed them early. If I have any questions, I would do a CT scan. One thing is that patients, when they're going to develop a leak or they have an abscess, they're usually not doing well. Usually there is something there. Even if the leak develops, let's say day 5, they're doing fine, and something doesn't look right. They start having a little bit of fever, white count is a little bit up, and that is a warning sign. Okay, maybe there is a leak. As Dr. Lundgren said, the early leaks are unlikely. I always tell the patients, I'm not worried, or the families, the first 72 hours. Around the 5th to the 7th days when I will worry about a leak. And so by then, usually the patient is tolerating diet. And if it's something that alarms me, I will stop. We tend to do early feedings nowadays, more like ERAs for general surgery, but there is not too much in that I cannot back this up with literature.
That's great. There's another question from Dr. Vasco asking about not using the drains, and I think that we discussed it already. So it seems that we wouldn't use the drains because sometimes you don't have the outputs from the fistula, and you may have contamination into the peritoneal cavity. So that's why the panel was considering not using the drains in this case. And also Dr. Kobe also asked another question here. What would you perform if you can't do CT drainage for duodenal leak when it happens? So I'll leave this question, Dr. Kobe just suspended for a while. I'll ask Dr. Palacios to go through the case. Maybe we can see if there was a leak or not, and we can discuss this. If not, we're going to address your question in the end of the session for sure. Dr. Palacios, please feel free to run through the case.
And the postoperative course, broad spectrum antibiotics, early oral feeding, and POD 6 discharge home. I follow up this patient after 2 weeks and no further complications.
All right. And how early was this early oral feeding? Do you remember the date?
The time to start feeding, I consider in the first fladus or when the defecation initially. That's two principles.
Perfect. So about Dr. Kobe's question, so what would you do if you can't do the CT drainage for a duodenal leak? So we are, I think Dr. Kobe is considering a patient who has a duodenal leak. This is contained like in some form of abscesses or any other form of contained fistula. So if you have this, what would you do if you don't have a percutaneous drainage by CT scan and you don't have any drains inside the belly? So Dr. Untracht, want to tackle this one?
Yeah, that's a great question. So this is basically the surgery of fistulas that was developed by surgeons not only before CT, before ultrasound. And so you have to diagnose it. What they would do is probably put down oral contrast, see where it was, take PA or AP and lateral views, and then what you try to do is this would be like a side fistula or wanting to form a side fistula. In other words, there's continuity of the duodenum, but this leakage out of the side. And in that case, the hole won't close until the abscess is drained. So basically, it's draining the abscess, and then in the days, not only before CT, before ultrasound, before antibiotics even. So what they would do is try and use an extraperitoneal approach to drain an abscess. So if it was posterior, like in Morrison's pouch, from the duodenum, which is likely where it would be. So they would use a posterior approach, go through the bed of the resected, is it 12th rib, I think it is. And then so you resect the 12th rib, and then you open the anterior perichondrium, and that puts you right in Morrison's pouch without entering the peritoneum. If you drain that, then and that's where the cavity is, then you'll have a controlled fistula, a controlled side fistula in the duodenum, and then you just insert a drain out when the drainage stops, and then the fistula will close. And then, and today in your hospital, if you have ultrasound but not CT, you do a CT, see the abscess, and then you can drain it percutaneously. You just make sure there's no bowel there. Put an aspirating needle, get pass a guide wire through the needle, take the needle out, and put like a cordis introducer or the plastic cannula part. Sometimes you can leave the introducer. If you have a pigtail, just use that. But you can improvise or just cut down on the guide wire into the abscess, leave a drain. The way you would do like an empyema, the empyema drainage, you just try and cut into the abscess cavity. And but the point is, and that's what Dr. Hockman was saying, that by that time you have a walled off collection, and that's when it works. So you want to take a side fistula with an abscess, and when you have a fistula with an abscess, you drain the abscess, the fistula closes. If the duodenum is completely ripped apart, then no, that doesn't work. Then you got to do some, basically bypass it or, improvise or feed below, drain above, or wait, drain the infection, let the infection resolve, and then do some kind of reconstruction. But those are the good cases when the surgeon had to do it, the way you couldn't rely on the radiologist. And the surgeons that had to operate before antibiotics, before fancy x-rays, just with a simple x-ray and echo, boy, those were the days. You really had to, you get creative about that.
Great. Dr. Hockman, any final comments or any other ideas?
No, I think that Dr. Untracht, kind of like his presentation, is really, I think he said everything. So sometimes I feel uncomfortable because we get so spoiled by the technology that we have, and I understand that this is the beauty of this conference. We see people solving the same problem that we solve with technology with ingenuity, like Dr. Untracht just described. I don't have anything else to offer there. Thank you.
That's great. Dr. Kassim, any final comments? And also, if you are up to, Dr. Herbert asked a question in the chat. So he asks, is a post-operative CT scan necessary in this case, even after a week, or no?
No, don't waste your money if a patient is doing well. Thank your Lord and say, move on. No, I would not do that. Regarding the drainage of a leak, it all depends on the size of the leak. If you have put a drain in, and if the drain is putting out a few cc of fluid, wait it out, be patient. Even if it puts out a couple of 100 cc, wait it out. Now, if he puts out liters of fluid, then you need to take the bull by the horn and fix it, because that is not going to heal in the long run. In the meantime, you have to address the patient's nutritional need, and you need to be vigilant about that. And then you have to make a decision when and how you're going to approach this leak. A small leak, leave it alone. Large leak, rethink, replan, and retreat. That's what I would do.
That's great. Well, Dr. Palacios, thank you very much for presenting this case. I think it was a very, very interesting discussion. We could touch base in several different topics regarding your case, the management, the diagnostic options, laparoscopy, open surgery. So I think it was really, really interesting, and we all learned a lot from your case for sure. So Dr. Untracht, Dr. Hochman, Dr. Kassim, thank you very much for being the panelists today. Once again, your comments were spectacular, and you were always giving us a lot of information and a lot of insights. And that's one of the beauties of this meeting as well. So everyone, thank you very much for being here today. I hope to see you next Monday in the next session for more trauma cases. Thank you very much. Bye-bye.